All right.
Okay, Greg, thank you very much for coming on my podcast. I guess this is the first podcast. I don't even know if this will see the light of day or whether I'll do another, but you're the first, so thanks for being here.
Awesome. The inaugural, right after the inauguration.
Probably people will be following it with just as much interest.
I am wearing Michelle Obama's outfit. I do look good in burgundy.
Well, so what's been going on the last year? If things were normal right now, you'd be traveling the world doing your famous course, reconciling pain science with biomechanics, I think it's called. I've attended. It's great. Everyone should go to it. You'd be, going to all over the world. So what have you been doing since that's not possible anymore?
I like not a lot. And that's the thing. Like, so the course went all pre-recorded 5 months ago, and I delayed doing that for so long because I wanted it to look good. I didn't just want to stand in front of a wall and
I watched it just the last few days, and it's excellent. I was impressed with the production value and the aesthetics. And
yeah,
the content I knew would be great.
Thanks. Yeah, I took a long time to do that to make it interesting because I really hate pre-recorded stuff, and I was like, I got to do something a bit different. It's still hard, but what I'm proud of is, it's a bit of a stopgap measure. But if people buy that, then they get to use the cost as a credit toward the in-person.
Yeah, so you can't lose.
That's what I think, and I know I'm so silly, but it's just I think I've taken so many courses in the past where you're excited when you take them and then you're not really sure and you kind of forget stuff. So that's why I always give out my Google Drive, I hand out my Google Drive, and I'll lecture notes from the past 6 years. But this is nice too because now you get everything pre-recorded, and then you can go through the academic stuff. There's more online than there is in person.
Do you have it more efficient, more boiled down and all that kind of stuff because it was online?
So it's more efficient, that's for sure. And that lets you get more information, just the nitty gritty, the sets and reps for power, hypertrophy. You know what? You don't want to just regurgitate information at people in person, but online is better for that, for just here's the stuff, now. Because in person, I like the discussions and the talks and the
right. So you don't have that. You take up that's a lot of good content comes from the questions and all that kind of stuff.
Absolutely. I always say if the course sucks, it's because the people in it sucked.
No, that's probably fair. So yeah, I saw your first one. I think the very first one you did, or one of the first, was in Seattle.
One of the first. Yeah.
And then I saw another one after that, and that was years ago. And you've done, I don't know, how many have you done? 100 of these things?
Hundreds. Yeah, I've been really pleased and surprised, and it's been nice, and it's really cool. Well, cool. I see my words out there a lot now, not even attributed to me, which is okay, because it's just a lot of it's just caught on, right?
Comprehensive capacity or movement optimism,
that type of stuff, like the themes and the arguments, where I don't remember seeing it 10 years ago and 8 years ago. It seems like I think it resonated with some people. So
well, you're good with those catchphrases, I mean, I think that there's a lot of information in there, and that it kind of a lot of times it encapsulates a lot of complex stuff, but it boils it down to something simple. I mean, what do you got? Comprehensive capacity is what you want to go for as you're a therapist. You say, you got a new one that I liked. I've got a shotgun. I'm not a sniper. What does that mean?
Yeah, that's that, because it's and that goes with the cup analogy for pain too. But we'll get into that. It's sort of like, or what I rather use, because it's less violent, is if you're a fisher person, you'd rather treat with a net than just a line, right? You more likely to catch some fish. And it's sort of, I don't know what has to change to get someone better. I don't think anyone does. And this idea that you find the thing that's so important, I find the specific problem or the specific driver of dysfunction, and then you're like, I'm going to fix that, and then you're going to be better. I mean, I try to do that. We talk about that. But at the other end of that is, I can't be certain. So let's work on building the entire system or the entire person, and use these big general things. Be as general as you can, which might be helpful. And then always consider how specific do you have to be?
Yeah. So let's say someone comes in that, people come in, big percentage of the time, it's going to be, I've got pain in my shoulder, I've got pain in my hip, I've got pain in my knee, I've got pain in my foot, I've got pain in my back. I mean, that's going to cover like big percentage of what you
Yeah.
do, right? How many conditions do you really feel like you really need a specific diagnosis as opposed to one of these diagnoses, which isn't really a diagnosis at all? Like when we say you've got plantar fasciitis, that usually just means your heel hurts.
Exactly. And same with the knee. Yeah.
Or non-specific low back pain, your back hurts. Most of the time, you've got a pretty non-specific diagnosis. How many times, how many conditions do you feel like if I don't get this specific diagnosis, something's really going to go wrong?
Yeah. I think I love that question, because I don't know if you remember, but that's how we start our course, the course. Like, when do you have to be specific? When is there, like, where are the cases where you really got to nail it and you have very few treatment options? And where I think they are like the more sinister pathological things, right? You still want to be a good clinician to treat in this general biopsychosocial way, where if like fractures, or if someone has low back pain, you want to make sure that it's not an abdominal aortic aneurysm, right? So like or like they get pain behind the knee, well, you certainly don't want it to be a deep vein thrombosis, but you also, or calf pain, you don't want it to be like a vascular problem from the spine, because that would have more of a, that would have a pretty specific fix.
So you can't miss those diagnoses. Those are specific problems. If you miss them, you've made a big mistake. You can't treat them as general problems. You can't say get a good night's sleep, or let's exercise
exactly
more.
Yeah, I think it decreases the problem. I think those general things of like nutrition and health and being optimistic will help a little, but I think you really need to fix the underlying driver there. Where if someone has like, just calf pain with running and it's not a vascular issue, it could be like medial tibial stress syndrome, or like medial exertion syndrome, or like a compartment syndrome, or a calf strain. And the treatment for those things are kind of similar, right?
Those are kind of diagnoses. Are those the kind of diagnoses that are just more descriptions of where it hurts, or are you referring to a specific pathology with those diagnoses?
So that's where, I mean, I kind of talked about something that is debatable, because like, so some people would say like an exertional compartment syndrome, like Andy Franklin Miller, he's a person to read there. He would say, well, that's just a biomechanical overload syndrome. You just do too much too soon for what you can
That's
handle.
just like saying you've got badness in the area, or the area is not prepared for something, or
like true compartment syndrome, that we'd want to be worried about that, because that might need a surgical intervention.
Right.
But if it's biomechanical overload syndrome, then you kind of treat it the same as medial tibial stress syndrome, which just means like it hurts on the medial tibia or in that area. Not even always the tibia. It could be the soleus or the tibialis posterior. You have no idea.
So, I was kind of curious about your course. How's it changed over doing it so many different times? You've gotten tons of feedback about what people already know, what works, and your ideas have changed as well. So, I mean, I saw the earlier versions, and I didn't really see the updated version as well, but I'm curious how you've changed it, whether in terms of like your ideas have changed, or you changed the way you present it, or has there been a change in how much people already know when they walk in, and they already know that, so you don't need to talk about it?
Definitely the latter. People are certainly more accepting, and which is cool too, because then we all just acknowledge that we have the same problems and same doubts, and then we work on getting better at that together. But this might surprise you. It's funny. I just talked to my wife about this today, because I was talking about you, and I said, I don't know how different it is. Like the fundamentals are still there. Like I have the same fundamentals. What I always try to do is challenge my fundamentals. So if anything, I might find more exceptions to what I think are the most important things for rehab and care, but still the fundamentals are there. So the course is, it's kind of bigger in a way. That's the only issue now. That the challenge is always, what do we focus on? And that's why I'm happy to have the online, because if we don't cover things, I can say, don't worry, you get free access to the online where
Well, can
do
you
that.
tell us the fundamentals? Because I like this.
Yeah.
I like, no, I got a question. So I like this fundamentals idea. You kind of start off with the idea that, okay, there's many different treatments. You got McKenzie, you've got Mulligan, you've got people doing manual therapy,
Yep.
physical therapy, and they all seem to be aiming at different targets, but they all hit them with kind of the same frequency, and they all seem to work like a little bit, none of them as well as we'd like. But they all, so let's look at what all these different things have in common. So what do all these things have in common, and what are your big fundamentals for treating pain?
Yeah. So when we look at, I think finding like common threads amongst people who disagree is always interesting, So, and what I often find is a lot of these people who seem different. So you could take the classic North American spine stability model of low back pain, and you could contrast that with the Australian, Peter O'Sullivan approach. One would be like, avoid. This is an extreme. I'm taking them to the extreme just for the point. There's always overlap, but it might be like, keep your spine in neutral, keep it stiff, all of those things. Yeah, to help with pain. And O'Sullivan is famous for saying, just flop, relax, bend as much
Let
as
it
you
all
like.
hang out.
Let it all hang out. No stiffness at all. And people think, wow, they seem really different. I'm like, they're the same. Those people would probably hate that when I say that. Maybe I'm onto something if everyone's angry. And I say they're similar because what they're both doing is they're finding ways for people to move with less pain, right? Where O'Sullivan is probably seeing a lot of people who are afraid to move, who've been told their spine is unstable, they need to brace, so that temporary avoidance pattern is now ingrained in them, and then it's causing persistent problems and getting in the way of recovery. So Pete is excellent at like building confidence and optimism in people and challenging their beliefs about that and showing them how resilient they are, gets them moving again with less pain. And then the big thing is looks at all the things in their life that makes them healthy, works on the multidimensional nature of pain, and then has them work on, meaningful goals and activities that they want to start doing again, and facilitates them adopting, like starting to do those things again. But at the North American model, which is your classic kinesiopathological model, they kind of do that too. They would want to find movements that are aggravating and teach people how to avoid them, probably temporarily. That there's some debate in there of how long that's where the debate is. So temporarily avoid, pain triggers or drivers, and then ideally get people back to doing the things that they're missing, like deadlifting and running and jumping and all that stuff. And recognizing that pain is biopsychosocial and there's other drivers there. So like they're kind of similar. I just wonder like if they're seeing different people, different people get attracted to those different models, and so it just reinforces the idea that they're so different. And I'm like, maybe I'm not sure how different they are. I think their fundamentals are similar in some ways.
It's similar fundamentals, but kind of a different strategies. And you said you had a phrase that I like. One of these strategies, the one that was the spare the spine. Let's try to stay in neutral. Try to move the right way. You called that correct and protect. And the other strategy you called more expose and adapt. And there's kind of a dichotomy there. And I thought it was kind of similar to your dichotomy, calm shit down, build shit back up.
Yeah. They're both
want to do both.
They're both doing that. I think they just disagree on the right way for the spine to move. That's sort of the idea.
Yeah. Well, if you're the kind of person that really believes in the power of the body to adapt, you're going to be a little bit more expose and adapt. Like if you're Sullivan, O'Sullivan, you're not afraid of exposing people to stuff that a lot of people, I mean, he gets in there and has people do stuff that's, I watched him and I was scared watching.
Yeah.
Because I thought, oh my God, he's going to flare him up. He's exposing someone to something that looks dangerous.
He's aggressive. That's for sure. And that's your Valayan. That's the Johan Valayan approach, when fear is driving the avoidance. And so that's the classic graded exposure, which isn't even that graded. It's more choose something not low on the hierarchy, but high on the fear hierarchy. And then
I'm kind of scared to do that. But that's part of what it means to be a movement optimist. Am I right? You believe in the
Yeah.
power of the body to adapt.
Yeah. And so there's a fundamental, like, and then the argument here is, okay, what catalyzes adaptation, and it's stress. It's challenging something. And so that's what, to me, that's what pain science is. It's just another stressor, right? Or having someone move differently, it's another stressor. It's both a biological or a tissue-based stressor and an emotional-based stressor. And we're trying to catalyze some change in the person that makes them reconceptualize themselves and their pain experience.
Uh-huh. Have you had experiences with people where you were maybe too optimistic about their ability to adapt to the things that you were exposing
Yeah.
to? You didn't fire them up and
Absolutely. And so that's why, again, this morning on Twitter, I brought up this idea, or like, I think another fundamental, every patient is like, you're asking yourself a question, right? And one that we always ask is, do I expose, right? Or do I protect, right? And for sure, like, sometimes we have to protect. And I would think sometimes I don't protect enough and I do too much exposure. Or the way I did the exposure still set them up to flare them up. I didn't have the precursors in place. So I've definitely had patients where you might laugh, but I'm teaching the neutral spine and hip hinging, and I was like, you know what? For a little bit, let's try this.
yeah.
You don't have to do this forever. It's just temporary, you know.
Yeah. So your movement optimism, your kind of belief that, I mean, in general, you would say that we've tilted the balance too far towards the correct and protect and not enough towards the expose and adapt, right?
Yeah, definitely like 8, 10, 15 years ago. I think it's shifting now.
Yeah. So in your own personal experience, I mean, you're an athlete, you've had pain, you've gotten yourself into pain, you've gotten yourself out of pain, you've adapted to different things.
Yeah.
I mean, what's your personal experience? Are you the type of person that does well at adapting to things after you've been exposed? Because I know that you've told some stories about, yeah, I had this really bad back pain, and then I went right out and when I went water skiing, and then I was fine.
Oh yeah. That was a neat one. But right now I used to do a lot of gymnastics, but with the lockdown, it's hard. And then I decreased it throughout the summer. And then in September, my shoulder started getting really sore because I was doing lots of renovations, but I really wasn't loading it. It was quite ironic. I'm like, I've been loading the hell out of it, and now I have very low load, and I can't put my arms over my head. I can, but it's sore. I can't do it violently, and that's the nature of gymnastics, is violent arm raising. But I didn't care because of lockdown. And then like 3 weeks ago, I was like, okay, this is a problem, because I signed up for a tumbling class with my 13-year-old. We're going to start doing trampoline and tumbling again. I'm like, okay, I gotta fix this. And so it hurts. Certain motions hurt. So I'm avoiding some, but I'm loading the shit out of it in the areas that feel good. So it's a balance of like expose. And the assumption here is you expose in these generally not sensitive positions, they will carry over to the sensitive ones. So I'm doing a classic, like a little bit of exposure and a lot of protection here.
Just load it. There's another good phrase. I don't know if that's yours, but you popularized it. Just load it.
Yeah, I think a bunch of people just said it at the same time. You know, it's kind of easy. It's just Nike. Like, it's not like we didn't invent calculus.
So I've got this kind of conjecture about musculoskeletal pain. Tell me what you think about this. Speaking of just load it, I'd say for a very high percentage of common musculoskeletal complaints, you know, my foot hurts, my knee hurts, my hip hurts, my low back hurts, my shoulder hurts, the kind of stuff that you see a lot. It hurts between my shoulder blades. I hypothesize that you can effectively treat that with a simple kind of algorithm, which would be basically something like just load it, do some strength training in that area for the muscles that cross that area, that are close to that area. Not so much that you're going to flare it up, or not so much that during the session you'll go past, let's say, a 4, not so much that it'll feel worse the next day, but enough so that you can stimulate some adaptations in there and get stronger, and you can progress it. So basically, you just kind of do some strength training in the muscles nearby the area that hurts without making yourself worse. My conjecture is that if you use that approach, it will very likely be on average, be just as successful as any other type of physical therapy you could do in that area. I'm sure there's some exceptions to that rule. What do you think about that?
Oh, I totally agree. If you look at what we do in our assessments, we try to recreate the pain, right? That's what all of our tests, we try to recreate it.
What hurts? What hurts? Show me
Yeah.
what hurts.
And then we make a call like, okay, are you avoiding that and not doing it? Or are you doing too much of that? So if they're already doing too much of that, then we probably back off. But if they're not, then we say, let's load it, like you said. And I would only massage your message and say, I don't know if it's strength that's mediating the recovery. I would just say you're applying some stress to get comfortable doing it again.
Yeah, I'm definitely not saying strength mediates the recovery, but if you do the strength training, you will maybe improve mobility. Maybe that's what mediates the recovery.
Yeah, totally.
Maybe you will improve awareness. Maybe you'll improve inflammation. Maybe you'll improve functional movement patterns. But you can get all that stuff from those strength training exercises.
Totally. If you have knee osteoarthritis and it hurts going upstairs, what are the exercises going to be? Knee extension under load.
Yeah.
And they'll eventually look like stair exercises. I bet you'll start with a wall squat or a knee extension. Then you'll do a squat, a regular squat. Then you do a lunge, and then you start doing stair step ups. And then you're like, okay, so the thing that hurt was stairs. What are we going to do? Well, stairs eventually. That's right. Like exercise prescription is easy in some way. The challenge there is like when to back off, when not to do it. What else has to change, right? Like, does someone have to believe that it's the right thing to do, right?
So, well, they have to if they're going to do the exercises for sure. Yeah.
Yeah, and the only time I would like say the idea of like the strength training is not the right thing, and I do lots of this, more of this now probably than ever, and I just don't know how to write it, and I don't really have any research on it. There's a subset of people who are always trying to fix themselves, like with a stretch, with an exercise, with the, I don't know, massage, like, and it's like hearing dripping in the corner, like, or in your house. If you just keep thinking about that drip, that's all you can hear, right? And you just perseverate. And I think there's a subset of people, when we keep trying to fix it, we make it worse in some way, right? We amplify our response to like a normal discomfort sensation, and we turn it from a 2 out of 10 to a 6.
Yeah, I'm kind of that guy myself. I know there's definitely people like that, and the people that come to me, I get there's not that many people like that out there, but the kinds of people that come to me, I get a lot of people that are like that, and then there's a lot of like talking them down from the idea that everything has to be perfect in my body before there can be anything less than a total disaster.
Yeah. And I find, and I'm not sure how you practice, but sometimes I'm like, no more rehab exercises, but we're going to do more. What do you want to do? Oh, rock climb, golf. Okay. So let's focus on those things. And if you need metrics, fine. It's the number of V4s you do when you're climbing, and the number of rounds you play, and your club head speed. So we shift there, because some people like numbers and to catalog these things. So that's what we focus on, is doing that stuff.
Right. So what else have you been doing? I mean, sometimes you're doing tumbling. I see sometimes you're doing rock climbing. Sometimes you're doing skateboarding. And then it seems like you shift between these. How do you decide which new hobby to take up?
Probably weather dependent. Can't do them all. That's the problem. Like rock climbing really got set aside this year, and I did more skateboarding. Like I might go skateboarding later, even though it's -3, but it's dry.
Ooh.
Yeah. So I might go later, and then, hockey, it's winter in Canada, so hockey. But now I'm actually strength training more than ever to build up my tumbling.
You're going to get that deadlift above 100.
I'd like to do 2 times my body weight.
That's all
you need. I don't really strength train. I kind of hate it, but now I'm actually enjoying it, which is weird. Yeah.
Well, what can you told this, you have this blog post that came out a while ago about a terrifying episode with stomach pain. Could you tell us about that? Because there's kind of an interesting pain science lesson that comes along with it.
Whoa. Yeah, there is. It's I had stomach pain like in August of last year. So, well, 2019. Didn't go away in a month. I've always had a sensitive stomach, but this was in a weird location. It was higher up, like where the stomach is, not lower down. Hurt, wasn't influenced by food or drink or exercise. Often felt better when I was exercising. Would be at night at rest. Went to the doctor, tried medications. None of that shit helped. Wasn't really given a diagnosis. We're 2 months in. I'm like really worried about it. When you can't recreate it or make it worse or better, you start Googling things, so I see like a specialist. We get the abdominal ultrasound, nothing on there, but I'm like, how sensitive is that? Checking out my stool and all. The doctor's like, your stool black? I'm like, no, it's not cool. And then what happens the next day? It's fucking black, And I'm like, what is going on? I'm not kidding, but I called like my insurance agent and increased my life insurance. I was considering not going to the doctor for a while as I increased my insurance, and then I was going to go just to make sure I wouldn't get like a claim denied in case I died. Like I'm thinking stomach cancer because it doesn't make any sense. I'm Googling everything. I'm thinking
How
about it all
much
the time.
how much during this time are you thinking this is a psychosocial thing?
Like a little, but it can't be that much. It still
Right.
fucking hurts. Like I know these things, and I'm like, fine, if it's psychosocial, I want to get the sinister shit checked out. So I get in, so 3 months in, I'm just as bad as ever. Still taking medication, not really helping. I get the scope done by this doctor, and she tells me, well, I'm all drugged up, that she didn't really find anything. But then like 3 weeks later, I have the follow-up, and it kind of felt better when she said that. But then I started thinking, does she really understand when I was asking questions about sensitivity and specificity? Like, because now they're going to do a biopsy of what they had. I'm like, I could still have something really sinister here. And I had my follow-up, and I was just terrified going into the follow-up. And I'm like, so I'm okay. She's like, what do you mean? I'm like, there's nothing really bad. And she's like, no. I'm like, I thought I told you that. I'm like, yeah, but I wasn't sure you understood. Like, I don't have she's like, cancer. No, you're fine. There's nothing. Like, she's like, I don't know. I don't really have a diagnosis. Do you want more follow-up to know what's going on? I'm like, I'm like, but there's not sinister. She's like, no, it's just could be this. I'm like, well, I don't care then. Like, I can have stomach pain as long as I'm not fucking dying. And then literally, like, I'm not kidding, within 3 days, like if it was a 7 out of 10, it was a 1. And then it's been like that for a year and a half or wherever. It's so unbelievable. I'm like, oh my gosh. Like, I still think there's something biological, like something tissue based going on in the stomach.
There's got to be something, right?
Without a doubt. But what I did with that was the disability and the suffering. And I would say that my emotions and my worry not only like had me respond to the discomfort and increase my discomfort, I would bet they actually did something physiological in my stomach to increase whatever was going on down there.
Yeah, it's not just amplifying a message, it's like going down there and changing the message because these are pretty connected sometimes.
And I think it's what we do with pain sometimes, with back pain for sure, and pelvic pain, is there's definitely something, or CRPS, there's absolutely something in the tissue, right? It's not all in your head, but our emotions and our past experience and our worries, they amplify what's going on. And so it always makes me wonder, like, what are we treating? Like, are we just treating our response to something that's in the tissue? And how often do we really treat the tissue? Because if you go around and poke everybody, like, I'm always sensitive. I'm doing testing of my lumbar spine kinematics. So my wife has to palpate and put the sensors on. And every single spinous process she pokes, I'm like, oh my God, stop pressing so hard. Like, everyone hurts. I'm so tender, but I have no back pain, but everyone hurts. And so, like, I think we all have this propensity for discomfort, but it's kind of what we do with it sometimes.
Yeah.
Right. And I'm not saying a lot of that there aren't issues where, oh no, it's really tissue, peripherally driven. That definitely occurs. But yeah.
Yeah. So do you like to, I mean, when you're thinking about all the complexities of pain, something that helps me is thinking, Is this a peripheral issue? Is this a more central issue? So, I mean, you could have, and when I say more central issue, you could have an issue with like the dorsal horn in the spine, which is more central, and then the brain is really central.
Yeah.
So like when you say with like CRPS that you know that's a situation where what's going on here can affect what's going on in the periphery, right? So it can get
Yeah.
really complicated.
Yeah, absolutely. And so that's why I always felt guilty or like subpar, like not a good clinician when I would take biopsychosocial courses and they'd list all these cycles, like all the factors that can influence pain, and then they'd have like a radar plot where you would try to say, oh, I think it's predominantly this one or predominantly that one. And you still see these models out there, and I'm like, I cannot do that. I have no idea what the most important thing is, because you can have depression. So just because you score high on a depressive scale, that doesn't mean that's contributing a lot to your pain. Do you know what I mean?
Yep.
A high score in and of itself, or you can have lots of tendinosis. That doesn't mean that that is contributing a lot to your pain. We have no idea. And so when you can't know, that's why I believe in treating with the big net, right? What do you want to work on, right? These are all things that could potentially be contributors. Not all of them have to change. What do you think would be, what would you like to do?
Yeah.
They say, I don't know. I would say, well, this is what I'm good at working on with you and coaching and teaching and being your therapist. But if I'm missing something, let's get some help too. Or if there's something you want to do that I can't do, well, then I definitely need help.
Well, I got a specific question for you about backs and kind of this peripheral versus central issue. What is going on locally or peripherally when someone's back goes out? So you know what I mean by back goes out. Their back is completely fine. Then they bend down to pick up something. And they go, ah, and then they can't move. And then they're all tilted over to the side and they're in terrific pain for a week and then gradually they get better and then they're completely fine.
Yeah.
So, you know, we say that, oh, pain's weird, pain's complex. There's a central thing. There's a blah, blah, blah. But I mean, I think that must be peripherally driven in some way, because why is pain so much weirder in the back than in other areas? You don't have weird, super unexplainable things going on in other parts of the body, but you do in the back. So what is going on locally, peripherally, when that kind of thing happens? In your opinion?
I have two theories. One is more my theory. The other one is more what has been taught for 30 years. The one taught for 30 years is this idea that it's disc related.
Yes, right.
And you can have, the way disc herniations occur, they start on the inside and they work their way out. Okay. And most of us will have disc bulging. So it's a normal occurrence, kind of probably unavoidable. But as you have that, like a disc changing and the material starts to work its way out, there's no nerves on the inside. So nothing is telling your brain or nervous system that damage is occurring. But at some point in time, it might the material could eke its way out to the periphery of the disc. Yes. And then that's where the nerves are like, what the hell is this? Right? We have never seen you before. What are you doing here? And you have this massive neuroimmune reaction, right? So you have like the sensitization where it's inflammatory driven. And to me, like inflammatory pain is like vinegar on a cut. It hurts like mad. So like you get an MRI eye scan, you hardly see anything. But when you have like radiculopathy or even like a little back pain episode like this, like it can really, really hurt. And so how long does it take to have for this neuroimmune reaction to settle down? 3 to 7 days, right? It's consistent with an inflammatory mediator, just this massive response. And some of us just freak out and you go to the hospital and you can't move. And then a week later, you're fine. The other theory is similar, but it's less structural. It's more like, and then I would say, as you get worried, we also increase like neurogenic inflammation and all of this stuff. So our psyche and, all these factors and the meaning of pain can all change our response to that thing going on. The other idea is very similar. It's like if you ever turn your neck quickly, you get like a jolt of pain, or your elbow locks during tricep extension, or you step on a stair and you have massive patella pain or kneecap pain. Like I get that stuff all the time. And I think that happens in the spine, where it's just a tweak, just some little weird tweak. It hurts. and might not be the disc. It could be anything. There's definitely nociception. But then we have this freak out reaction where we overprotect, and now the muscles jump in, right? And they start squeezing. And then we have a neuroimmune reaction where it's neurogenic inflammation driven from beliefs and worries and fears and all that stuff. And then we actually, I don't want to say cause, but we like our emotion, like we actually cause the problem. And then slowly over time, that just settles down. Same thing, right? So kind of the same pathway. It's just what the difference is. What's the instigating factor?
Yeah, those are
It's like
great explanations. I kind
it's
of
like a
like the
bee
first
sting.
one in terms of like the specific instigating factor. But what they both have in common is something new happens, something's threatening happens, the whole system freaks out, and there's
Yeah,
a prolonged reaction to it. And eventually it'll probably figure out this is not really a problem,
yeah,
and kind of return to normal. It reminds me, I always think, I like to think in terms of like the TSA. The TSA is the American version of all the security you have at
see something, say something.
yeah, you see something, say something. So at the airports, but so that's the low level. There's a bunch of low level people at the TSA that are just looking out for anything and saying, if you see something, say something. You know, the machine's going to buzz. But then there's this whole kind of like group intelligence to the whole system, which is not that intelligent at all because it gets traumatized by like some guy, the shoe bomber guy.
Yeah, yeah.
Like there's this shoe bomber guy that comes in and tries to put a bomb in his shoes. That's why we're all taking our shoes off today.
I know.
I don't know if there's a single person in the whole TSA that believes that's necessary, but the institution as a whole has this institutional memory of that. It'll never fucking forget. And so we're all going to be taking off our shoes for the rest of our lives because it can't get out of this weird traumatic memory that it has of that. And you don't even need anyone to actually believe that you need to take off the shoes, but the system as a whole now, believes that.
Yeah, that's it. It's like we overprotect and we overreact because it's safer to do so. And then we get better at overprotecting
And
over
especially
time.
when there's this really dramatic event. So there's all sorts of dangerous things that are happening at airports, but this one really gets a hold of people's consciousness. It really gets their attention, kind of like that feeling when you get a huge spike of pain for no reason. All of a sudden, it really
Yep.
gets your attention, consciously and the whole nervous system, and it reacts.
Yep. It's like a panic attack of the back.
Yeah, that's cool. A panic attack of the back. I like that. So I wanted to ask you a question about John Sarno. You ever read any John Sarno books?
Like I did in 1991 when I was like 19, or no, not 91, like 93 when I was like 19. I used to
Yeah.
always read his stuff. So I've been in on this stuff
So
for
you've been woke for a long time.
forever. I wrote a paper on central sensitization in 97 for an ergonomics class.
When did you get started with your education? Now you've been to Cairo school, you've been to PT school. When did that start?
92 was when I started kinesiology, and then a master's in 96, and then
So
Cairo in
there must have been a
99.
time when you were, not woke, when you kind of believed all of what was being taught in terms of, this is the wrong way to posture yourself. And
I had conflicting stuff from the start because my biomechanics professors were very much, biomechanics is very important in neutral spine, but the men, it was mostly men at Waterloo. It was all that I haven't. No, it's pretty bad. The biomechanics professors were teaching how important psychosocial was in 97. I remember Bob Norman, it's a great professor, did a debate with maybe it was Michelle Bache at NACOB, it's the North American Congress on Biomechanics, and she argued for the psychosocial factors being more important than biomechanics. And he had to argue the biomechanics side, but he said, I don't really want to do this. It's not just biomechanics, right? So I learned really young that it's an interplay. Although what I think happened through my career is maybe earlier I thought I acknowledged the psychosocial, but I still thought biomechanics was leading.
Yeah.
And I still think that sometimes. I don't know.
Yeah. Well, that kind of raises the question of, are we making any progress here? I see you occasionally point out how there's, mainstream ideas out there about how to treat pain that really should have gone away quite a while ago. 2 decades, 3 decades, we had really solid information that that we shouldn't be doing this or we shouldn't be thinking this. And there's this idea that we're going in circles or we're not making progress or we're not learning. So what do you think about the ability of this whole institution, which treats these common pains, which is the biggest medical problem in the world? What is its ability to make progress and learn from mistakes and go forward?
Yeah, I think, to be honest, I am an optimist where I think because we don't understand pain very well, I think a lot of things can help people, right? But we get caught up in thinking we know the mechanisms, right? Or that there's a right way to do something instead of really trying to find, again, the common threads of good treatment. And I think when you simplify and just sort of find the common threads. So I'll give you an exercise example. Well, I think biomechanics is important, just not the way it's traditionally been done, right? I think like what you said, your exercise prescription for back pain, that's great. That's probably the primary thing. So let's stop discussing the right exercise and let's focus on the bigger questions that we aren't asking, or the other questions that we aren't asking to improve our skills. And I don't think we do that. We get caught up in having debates about don't let the TFL turn on when you do a hip abduction exercise for IT band pain. Make sure it's just the glute medius firing and the glute max, because you'll tension it, and don't go into compression or something like that. We have all these little rules and we have those debates, and that isn't where we should be spending our time. We should be spending our time on like what we don't know and what we should be adding. Or yeah, I don't know, that doesn't really answer it, but that's my take.
Well, it doesn't totally answer it, because what I kind of want to ask about is, are we, is the science teaching us anything?
No, it's certainly not. We're not there. Louis Gifford would have practiced just like me, 20 to 30 years ago, and everyone could read his books and learn a ton.
So are you kind of a pessimist about it? Are we about making progress towards getting away from these really biomechanically oriented approaches?
I don't think we are at all. I think biomechanists are doubling down and measuring more things and still saying, no, we just haven't measured it the right way. If we get more information on the loading on this part of the knee, then we'll be able to make it. And we got to measure the cumulative load with these running metrics. No, I don't think we are at all. But then what they'll do is they'll dress it up with psychosocial talk. We have to look at sleep and all these other things, but they really want emphasis on all the other stuff. So I don't think so. I think it's getting more biomechanical.
So the pendulum is not swinging.
I don't think so. I think it's over there, and maybe they're adding stuff onto it.
But you have more and more people, going to your courses and kind of knowing what's going on in your courses. Do you think that there are, maybe kind of like some subfaction of the whole, which is getting?
Oh yeah, I think so.
Yeah, but I guess there's not any kind of is the education for PTs changing the way things are taught in schools?
So I can only comment when I have people who take my course who are like teachers. So it's very select. So I think at an individual level, it is. There's a lot of, and I think the vast majority of teachers are well intentioned in the training. So they're just trying to do their best. And I completely understand that. Like someone was shitting on ultrasound the other day and saying it wasn't like, why is it taught in the training programs? When you actually go look at the research on ultrasound, you can find systematic reviews saying it's okay, right? Like, so how can a professor, if they've always done it and they have good clinical results with it, not teach it if they can also quote an SR saying it? You know what I mean? Like so there you have systematic reviews saying ultrasound is okay. But some people say don't teach it. But then at the same time, you'll have clinicians say compression is horrible for the tendons. It's evidence-based, where there's hardly any research on that, but now that's accepted dogma, right? So it's weird. Like I just have trouble blaming any teachers out there for putting in some things that some people hate.
Yeah. And if you're in the more, if you're in the more if you're in the more kind of psychosocial ends of things, and you'd like to see that emphasized more, and you spend all of your time critiquing and being skeptical of the people that do ultrasound or more biomechanical approaches. If you applied a similar amount of scrutiny to the research
Yeah,
and the benefits of therapeutic neuroscience education,
absolutely.
you probably have a lot to complain about there as well.
No, the things that I teach and the way I practice, I know that it could be and it should be easily scrutinized and critiqued. Yeah, and if we're consistent in our criticisms, well, then you should just be as doubtful as I am of certain things.
Yeah, yeah.
I just have trouble telling someone that they suck.
I
Right?
don't think you're that bad at it, really. Don't sell yourself short.
No, it's weird. It's very nuanced. When I question people, I'm like, you can't say that so strongly. It's not fair. Like when people say, don't stretch tendons, I'm like, huh? How can you say that so with such strength?
Well, tell us a little bit more about stretching tendons. You've kind of presented some interesting facts about that
Well,
recently. That's a little bit
I,
different than
I,
other people say.
I'm a good person to talk about stretching because honestly, 20 years ago, more than that now, I was very much against stretching and I knew all the literature and I just thought it's stupid and a waste of time. But I think I jumped, and even 5 years ago, I wrote a paper with Kieran O'Sullivan and Sean McAuliffe about why we shouldn't stretch and it's overrated. And I've backed that up. Like I've backed off of that. I think it's too strong an opinion that we made these strong opinions without really good evidence. Like there is some evidence that stretching before activity will prevent some muscle injuries. Like you can look at the work of, is it David Bem? Yeah, David Bem and Blazevich and these systematic reviews. But people ignore that. They just quote some other systematic review, right?
Uh-huh.
So what with tendons, what you hear is people will say, don't stretch a tendon. It's that there's no evidence for it to help a tendinopathy. But then you're like, well, have you ever directly compared it to a loading program? No, those studies don't exist. Or with a progressive loading program for Achilles tendinopathy, has that ever been compared to a non-progressive loading program or a really good sham exercise program? No. And in the hip, when it's been compared for gluteal tendinopathy, the Ganderton study, there was no difference between the groups. Progressive loading protocol did not outperform a
the only
sham.
kind of load that a tendon knows, right?
Yeah, so that's tension. So then what people will say is they'll say, it's not the stretching, the tensile loading that's problematic. You don't want to do stretching because you have to go to end range. And when you go to end range on some tendons, there's a compressive force between the tendon and the bone. So if it's an insertional Achilles tendinopathy, the Achilles tendon will pinch or squeeze against the calcaneus. If it's in the hip adduction will cause compressive loading, at one of the glute med or glute min tendons. And so the basic science research shows that sometimes you have more tendinopathy or tendinosis at the compressive sites. That's it. No one's done a study like showing that, if you don't remove compression, these people won't get better, or removing compression or not stretching is superior to exercises that have compression loading. Right?
Yes,
it might be. It absolutely might be. It's potential, but no one's tested it. Right? They'll just say, well, in my clinical experience, compressive loading is harder on the tendon. All right. And then I say, well, how do you decide not to do it? Well, it hurts. I'm like, okay, so you're just telling me don't do something that hurts for a little bit. Great, no problem. I could have told you that too.
Yeah.
Right? I have no problem. I have no problem with that. Right? And that's what I mean.
On the tendon.
Yeah.
It's the stress on the tendon. Why can't the tendon adapt to get better at that kind of stress? That's the job of a tendon. It's not like tendons didn't know there was going to be compression.
Exactly. So
I
then
didn't
you
know
go
there
back.
was going to be compression here. I am just a tendon.
Yeah, exactly. So that's why I made a joke this morning, and I said and I've actually said this for 6 years. I'm like, is tendon compression the new spine flexion? Why are we so worried about it? If it hurts for a bit, okay, avoid it. But what's interesting is, especially in the tendon literature, we see that people or in the hamstring rehab literature, or in the shoulder, we see that people don't underperform when they do exercises that are painful. So maybe it's not even a factor. Maybe you don't even have to avoid it, right? So that type of study would have to be done. You compare a progressive loading program without stretching to a progressive loading program with stretching and no avoidance or minimal avoidance, and then then you can start saying strong like conclusions like stretching and compression is bad. Until such time, say maybe, I guess, kinda, this is why I think so. It could be. Like, be a little sheepish and humble.
Sheepish, good. So what other studies like?
I'm arrogantly sheepish. I have a weird. My wife doesn't understand me. I am like humble and humility here, but I guise it in arrogance. I don't know. I can't.
I see you.
I'm a special person.
I see it. I see the humbleness. So
Yeah,
let's
arrogance.
say that you've done research. Let's say you had all the money you want, all the time you want. What's the first 3 or 4 studies you can do and then figure something out and answer a question that's kind of on your mind?
Oh God, that's like, I don't know. I have so many interests here. What type of studies I would do? Oh, that's hard, man. I'll speak more in broad terms. My favorite areas is related to this. It's expose or protect. I really love those studies, like Karen Silbernagel, Jack Hickey, these ideas of like poking into pain. Even like the work of Shirley Sarman and that group, like Baldwin, I don't know her first name, but these ideas of like, do we have, or the running literature with hip adduction being associated with knee pain. My big question is like, do we really have to change how people move to get out of pain? Or can we do other things that allow them to tolerate those sensitive movements? Right. That's what I like. That's my favorite question with rehab. Like, I kind of acknowledge there's going to be drivers of sensitivity. Do we have to fix those, or can we just build someone up or develop some other attribute so those drivers of sensitivity are no longer a problem?
Right.
Like that type of that's exciting to me, because like I like that with the psychosocial. Can you be fear avoidant and perseverator and catastrophize, and that's just who you are, that's your trait, but never really have to change that, but you develop some other ability to tolerate those things. So it applies across the board with the biopsychosocial. It's not just a mechanical thing.
Uh-huh.
Yes.
So you're always interested in what's mediating recovery.
Yeah, that's it.
But it's just so hard to figure out, isn't it?
Oh, absolutely. So I never shit on researchers. If you publish something great, like everyone's like, why didn't you do this? I'm like, you know how hard it is to do those studies? Be thankful they did it. And now someone else can follow up.
It's very hard. I mean, I've been, reviewing research now for the Physio Network for a year or two, and I read these papers in detail and, on a variety of topics. And I remember reading one on like the question of whether the weather affects arthritis.
Right.
Everyone, the humidity bothers my knee, or the when it's cold, that's when this hurts. And should I move to Arizona? People have been looking at this for a long time. It seems like it should be pretty easy to figure out. You can track people's, daily pain journal and then correlate it with the weather. And is there a correlation? Seems like that's not that hard to figure out, but they've been studying it and studying it and studying it and studying it, and they can't freaking figure it out. And it's like more research is needed. And I was like, we're never gonna learn anything about anything.
Yeah. No, I know. Even simple things like you would think, like with knee pain, patellofemoral pain syndrome, you'd think we know if quad weakness was a risk factor. Like that, people have said you got to strengthen your kneecaps for years. And when you look at the literature, this would be Brad Neal's systematic review. It's only a risk factor in 2 studies in the military population. That's it. It's not even that well studied yet. Yet strength training seems to be helpful, but is it because they got stronger? So even something like that, like just the strength.
Do we know whether
mediate
strength
recovery
training protects you from injuries in running?
No, that's a perfect question. There's 2 papers that have studied it, and everyone said, and they didn't find it to be protective. Maybe kind of 3. There was another like preparation one, and everyone's, because people want to say that strength training protects you. It makes sense, kind of, and they'll say, well, that wasn't a good enough strength training program. And which might be true. So the strength training programs they did in those studies, I think one was Carolyn Emery's research, and I forget the author of the other one. I do know one of the authors was he's the Jordan. It doesn't matter. I haven't thought about that for a while. But it wasn't successful. Yeah.
Okay.
Yeah. Sorry.
What about other sports? Don't we have pretty good information that strength training is going to protect you from injury and soccer
yeah. I mean, the nicest, you have these general studies where they just look at overall injuries, and in general, it's protective at a individual injury level, like hamstring. You see that definitely Nordic hamstrings help. Other ones might help too, but they've just studied the Nordic hamstring. It's not a massive reduction, but it's still there, at a team level. Definitely seems to help with recurrence, like recidivism, if you already had one injury. At an occupational level, people who strength train or exercise, that seems to decrease low back pain, right?
Right.
So there's something there. Nothing's like nothing makes you bulletproof. Those things online, but it decreases your risk.
Wait a minute. You can put butter in your coffee and then you'd be bulletproof. I know that.
Yeah. Oh, if you do squats with it. Yeah. In your hand.
So, I'm taking about an hour of your time. I don't want to take too much more, but I want to know what are you going to do when this lockdown ends? What's your plans for the future?
You know what? I want to get back to traveling and teaching. And I want to get the hell away from my family.
You got to do it.
And they want me gone too.
That's probably a two-way street.
Oh yeah, they're waiting for me to
Mutual.
leave. I actually did travel in September. Everything September, because I went to Vancouver and Denmark, where there was like no cases, and there's no cases here in Toronto. So that was nice to get away for 2 weekends.
Well, let's I'll hope that you can get back to traveling soon. That'll be good for you and good for everyone who takes your courses. And where can we? We can get information about you at greglehman.com. greglehman.ca.
Yeah, Canadian.
What does CA mean?
Canadian, maybe.
Where is Canada?
Chartered accountant. I think it's north of Mexico. I don't know where it is relative.
There's something in between.
Though.
Anything else? Any other messages you'd like to leave with my audience, or places we can find you, or upcoming stuff, or plugs, or anything?
Not Facebook. I hate Facebook. I'm doing more on Instagram. That's been fun. I've been like putting stuff on besides my tumbling and my narcissism. And then, but I don't really like discussing things on Instagram. I do like Twitter, and you know that. And you're like, get off of Twitter, get on Facebook.
No. I've changed my mind. I got a Facebook too. And I got, and not that I'm on Twitter or anything, but I used to complain to Greg all the time that he would have these conversations on Twitter, which seem totally undermined by the fact that you only get a short amount of characters, and they would like have this argument for, like this massive confusing thread, and then find out at the end of it that they actually agree with each other because no one could figure out what the other was saying. So it's also short and quick when it could have been worked out in Facebook. But now I think that the shortness of Twitter is more of a feature than a bug, because a lot of these conversations are useless even when you do understand. I mean, Facebook is conversations to me suddenly got very, very bad around last year, and I just got out of them.
Yeah, I know. Yeah, me too. Yeah, too many, too much.
But thank you very much for coming on, Greg. I appreciate it.
Yeah, thank you.
Okay, I'm gonna hit